wanted to officially welcome you to my podcast. I'm very excited about today's topic. I'm an internist, a primary care physician. So I spend a lot of time talking to women about their breast health and mammograms and all of that. But as there's a lot of time shortage and going over however many things that we have to do, I can't spend even 15 minutes talking about breast health. So a lot of patients have questions about how they can reduce their risk of breast cancer. And then along comes you. And I was like, okay, this is a great way, having a lot of information in one place where patients can refer to. And obviously, more than patients listen to my podcast, people in general. So wanted to learn more about you so my audience can hear what inspired you, Ramsey, to become a breast surgeon, a breast specialist.
Yes. So when I was in medical school, I really enjoyed surgery. I loved my surgery rotation. I loved anatomy. So I decided that I wanted to do surgery. And I always had an interest in women's health. I have we have a lot of strong women in my family. My grandmother actually had breast cancer. So it's something that I was familiar with growing up. And so when I got to surgery, I just really was attracted to breast surgery. And specifically because you get a really good relationship with the patient and breast surgical oncology. I love just counseling women and having clinic and getting to talk with them and like the emotional side of breast cancer as well. I feel like I can really connect with the patient and be there when they're very overwhelmed because they have a breast cancer diagnosis and they don't know where to go or what their prognosis is. So really that attracted me to it. You get to both do surgery, but then also have a really in-depth connection with the patients. And then also have a longitudinal relationship. So I follow my patients every year for many years after their treatment and they're recovered and in survivorship. So it's really cool to see the whole journey. And that's what really attracted me to breast surgery.
There's a lot. And I work very closely with the breast specialists in my practice. So following those same patients together, I get to see, obviously, review their consultations. And I think that you have a very different relationship with these patients than, let's say, other specialists. It seems to me that it's a lot more personal. So I do like that aspect as well. There's a lot that has come out recently, especially the use of alcohol, and the Surgeon General has stated that even moderate consumption of alcohol can increase the risk of certain cancers. Is breast cancer one of them?
Yes, breast cancer is one of them. We knew that before even the Surgeon General released his statement, but I think now it's very important that people are realizing that. And I did like his call to get labels on the beverage bottles just so consumers are aware of this risk. And it's a risk factor. It's not going to be a direct cause and effect relationship. I don't think that we can say, oh, you got this breast cancer because you were drinking alcohol. Like, no, there's not a cause and effect, but it's a risk factor. And there's so many different risk factors as we'll get into. So I think that if you can eliminate one, but it also has so many other health benefits as well, not just reducing your cancer risk, but it's just something to be aware of. And if you can cut back completely, that's the most ideal. But if not, then we say no more than 3 drinks per week. Ideally.
I also have patients who are in their midlives who are either perimenopausal or menopausal. And they've noticed that at some point, unlike their 20s or early 30s, that alcohol isn't always their friend. They've noticed that they have more symptoms, more irritability, more fatigue, more hot flashes. How do you explain what happens to the body? And do those kind of symptoms signal that they may be at higher risk for other things as well?
I think it just has to do with aging and cellular aging. As we get older or our cells get older and we can't process things as much as we could when we were in our 20s and could have drinks and be up early and just be going for it. I'm only in my 30s, but I feel like I already feel some effects like that as well. And then other stressors add on too. When you're younger, you maybe aren't as stressed about family stuff or work things like that. So I think when you're combining alcohol, which we already know has negative effects on, for example, sleep quality, but then you have other stressors as well, it adds up. And then your general health, maybe you've developed heart disease or diabetes, and you're just as you get older, unfortunately, you are at risk for diseases and even cancer. We know that one of the risk factors is age. I wouldn't say that necessarily means they're at a higher risk, but I think that it's a sign that if they're not feeling good and they're feeling these effects, then it's obviously not doing good for their body.
As I mentioned to you, a lot of patients come in and they want to know what they can do to reduce their risk, especially patients who have a higher risk due to genetics and or if they have other types of cancers in their family. How do you typically guide your patients when it comes to everyday things, lifestyle choices, what they can do better in terms of what they're eating, how they can store their food, to screening and testing?
Yeah. So we'll start with the everyday ways of risk reduction. Lifestyle factors, exercise is key one. The American Cancer Society recommends 150 minutes of moderate intensity exercise a week. So if you could get out about 30 minutes, maybe 5 times a week, just keep that 150 minutes in mind. In moderate, I'm not talking about, we don't have to be high intensity training here, but things like brisk walking, swimming, water aerobic. I personally like Pilates. I've been doing pickleball. Tennis is a good one. Or even activities like gardening, moving around the house, things like that. Just staying active. And if you can do that, as I said, for 30 minutes a day, 5 days a week, that is very helpful to reduce your risk of cancer. Going along with that, maintaining a healthy weight. Obesity, we do unfortunately have an epidemic of obesity in the United States. And your body actually has an enzyme that can convert fat into estrogen, which can fuel hormone-sensitive breast cancers. So by reducing your weight, reducing excess fat, you are reducing your body's estrogen, especially for postmenopausal women. That's the estrogen that their body is seeing. So with exercise, also weight loss, and then along with that, eating a healthy diet. So I don't have a strict diet that I tell my patients to follow, but really just whole foods and minimally processed foods. The overly processed foods have seed oils and these oils that are just not good and can be associated with inflammation. So just as the most whole foods they can eat, fruits, vegetables, things that aren't processed, that's what I really promote. Also protein, lean proteins, and obviously vegetables. Those are diet, exercise, and weight loss are very important. When it comes to food storage, there have been some studies showing that some of the chemicals that can be in these storage, especially plastic packaging, can actually leach into the foods. And these chemicals are endocrine disruptors, so they can affect the hormones in your body. And breast cancer is a cancer that can be sensitive to hormones. So I tell them, don't microwave things in plastic because you don't want that plastic melting on your food and kind of leaching the chemicals into your food. Also using a glass water bottle instead of a plastic. And just being aware that all of those tightly packaged foods can also have chemicals that could affect your hormones.
I'm going to bring up some questions that come up sometimes through patient portal messages or even when patients come to see me. I had a patient recently who said that she read an article saying that her Mirena IUD put her at a little bit of a higher risk for developing breast cancer. Is that true and why?
Yeah, so it is true. The why is that it's thought to be related to the progesterone in the hormonal IUD. So the Mirena IUD does have progesterone. It is local. It's not systemic because it's in the uterus. However, they did do a study that was published recently, so it's been in the news. And the Mirena has been shown, or hormonal IUD has been shown to slightly increase the risk of breast cancer. And the risk is small, though. I don't want to alarm patients. It's about, when they looked at the numbers, it was about 1 in 1,000. So it was a very small risk. And this is similar to the risk of oral contraception pills, so your OCPs. We know that those also have a slightly higher risk of breast cancer, but they are protective against other cancers. So they are protective actually against ovarian and endometrial cancer. So I don't think that this is something that patients who are at an average risk of breast cancer need to go get them removed. I wouldn't say it's alarming, but it's just something to be aware of, that it can slightly increase your risk. However, there are many other benefits. Patients that have very heavy periods or regular bleeding, they can help patients a lot as well. So it's weighing the risk versus benefit. If you do have a very strong family history of breast cancer, or say you do have a genetic mutation, then maybe you would want to consider the copper IUD, which does not have any hormones.
Yes, that's basically what I said to her, but obviously this is for a broader audience. So I think that answer is great. And I think, it should help a lot of women who are hopefully listening. Another question that comes up, and as the world of perimenopause and menopause and HRT has just swung in a totally different direction. And there's some very good things about that. But there are times when I have patients who have been menopausal for a bit. So they may not be in their 60s, but they're in their late 50s, and maybe menopause happened to them. I'm making up a number here at 51, let's say. But they had a family member, so let's say a sister who had breast cancer around that similar age. And they come to me and say, I really don't know what to do here. I'm suffering with a lot of menopausal issues. How do you usually guide your patients when it comes to those kind of situations?
Yes. So I do think that this is very exciting with this, because there has been some new research coming out, especially in breast cancer patients as well. One thing that I do tell my patients, even if they do have a history of breast cancer, is that the studies have been showing that vaginal estrogen is safe. So if that's most of their symptoms, dryness, that we can do vaginal estrogen. It has not been shown to increase the risk of breast cancer. So that is reassuring, because I think some people thought that there's absolutely they can't have any, even if it's local. So I think that if a person doesn't have a history of breast cancer themselves, then it is safe to do hormone replacement. It does put you at a slightly higher risk of breast cancer. But if the symptoms are intolerable and they're suffering, then I think we have to, again, weigh the risk and benefits. And the benefits might be that it makes them feel so much better. And maybe they're getting sleep, and then they can exercise and do other things that can reduce their risk, instead of just living with this torture, basically, from all these hot flashes and everything. In breast cancer patients, of patients who've had a history of breast cancer, there's research ongoing right now about if HRT, not just the local one, as I said, we know that's safe, but if that this is safe in breast cancer patients. So that's ongoing. I wouldn't recommend it for a breast cancer patient if they had a hormone-sensitive breast cancer. If they did not have a hormone-sensitive breast cancer, then it is okay if they had a triple negative. But if someone had just a family history, maybe just one family member, then I think it's safe. There's concern for a genetic mutation if they had multiple family members. If their family member was diagnosed at a young age, things like that would make you more suspicious for genetic mutation, then maybe you should get genetic testing before doing it. But I think overall, it is safe, just knowing that it could slightly increase your risk.
Do you have more patients coming in to see you because since this movement started about what they should be doing?
Yes. So do you mean about the HRT, or just patients and cancer patients or people who want to reduce their risk of breast cancer?
A lot of patients who come to see me, at least, I'm not saying that they all follow with breast specialists. That would be actually very remarkable. The ones that do, they often feel confused because they're like, okay, my mom had it, but I'm not sure if it was estrogen positive or not. And my breast specialist is saying not to, even though I'm suffering. So I'm not putting this on the breast specialist, but a lot of people are questioning what they should be doing. And this has come up more in the past year or so than it ever has in the past.
Yes, I know. I do see patients who are at a high risk of breast cancer, and then I see my breast cancer patients. So when my breast cancer patients ask me, I say it's okay for topical. I would probably not recommend doing the systemic, especially if they're close just to their cancer diagnosis and their treatment. But yeah, I think just being open-minded about things and really talking with patients and treating everyone as an individual, because as I said, it's not worth to be living if you're suffering. So I think that if it's really unbearable, then it's something that we can discuss, and maybe then we just keep a closer eye on you.
I have another patient who went through menopause at a much later age than the average woman. Menopause for her started. She's not officially menopausal, at 58. And one of her questions was she read that because menopause happened later for her, that she was also at a slightly higher risk for breast cancer. Is that true?
It is a small, very small risk. So basically, breast cancer risk when it comes to gynecologic and reproductive history is that the more estrogen or more periods or menstrual cycles that a woman has over their lifetime, the higher risk they are for breast cancer. So if you start your menstruation earlier, when I do think that this is one of the reasons why we're seeing higher rates of breast cancer now too, is that there are actually young women are starting their menstrual cycles earlier. We don't really know the reasons why. One of them might be obesity or hormonal factors. But so starting your cycles earlier, and then obviously then if you have menopause later, you're having more cycles over your lifetime. And that can slightly increase your breast cancer risk. There's nothing really to do. We don't want to say you can't really change that, but it's just something that we look at, and it's taken into account in some of the risk assessment tools. So if a doctor is going to say, let's do your breast cancer risk assessment, they ask things like that. What did you start your cycle? When did you menopause? How many times have you been pregnant? Because pregnancy is actually protected because you're not having your periods during those months when you're pregnant. Did you breastfeed? So we take all these factors in, and then we can give you a kind of percentage of your lifetime risk of breast cancer. And then that helps us decide how often you should do your screenings.
What other guidelines do you recommend to patients? There's so much out there in terms of information. And as patients sometimes go to social media, right? And then they follow oftentimes misadvice on things like TikTok and Instagram. How do you direct your patients so that they can be going to the right sources and not getting misinformation?
Yes, that definitely is tough, especially with, as you said, all the access to information on the social media about how do you know who's actually legitimate. I direct them to the American Cancer Society because their recommendations are always very solid and they're backed by research. Also, when it comes to screening guidelines for high-risk patients and treatment protocols, I direct them to the NCCN. So that's the National Comprehensive Cancer Network. And they have guidelines for patients. It breaks down if your risk of cancer this is the screening you should be getting. And then when it comes to cancer patients, if you have this type of breast cancer, these are the surgical options, and a flow chart and walks them through it. So I think those are two very reputable sources. And then also just coming in with us and having established follow-up in our clinic so we can answer their questions and talk to them with studies that are evidence-based.
Mentioning the studies, right? I know that there's been a lot of research going on in the world of breast cancer. What exciting developments may be on the horizon that we don't know about that you can educate us about?
Yeah, so there's a lot of advancements when it comes to patients who have advanced breast cancer, metastatic breast cancer, a lot of new developments with specific drugs and not just chemotherapies, but immune therapeutic cancers. So a more personalized approach to treatment, not just this one size fits all of cancer medications. So one study that I saw that was cool, that this affects everyone listening, just any woman who doesn't have breast cancer. It's actually called the Wisdom Study, and it is looking at our recommendations right now for screening, which are saying that if you're an average risk woman, that we recommend getting an annual mammogram starting at the age of 40. But the Wisdom Study is specifically looking at how we can do a more personalized approach to screening. And maybe you don't have to get a mammogram every year, or maybe we're going to alternate with something else. So it's reevaluating our thought that we need to get mammograms every year, and how can we make this better based on the individual patient. So I think that is very exciting, especially as we're moving towards more individualized care and screening and what might be better for a specific woman.
So would that mean that certain women don't need a mammogram every year, or they might need more? Yeah.
Right. So I think that there'll be some sort of screening every year. So if it's an ultrasound or a mammogram or some sort of other imaging, an MRI, we're not just going to let women go. However, We're going to see what the best modality is, and to really just keep track of that woman and hopefully to find breast cancers, but yeah, maybe find them earlier in some patients as well.
I've asked you a lot of questions that I think that women will be paying very close attention to. Are there any other topics that you would like to talk about that I have not touched on?
We have talked about a lot. So great. I think if you're a high-risk patient, so if you know that you have a family history of breast cancer, or if you did an assessment and your lifetime risk is over 20%, that a lot of breast surgeons, myself, a lot of people, we do see patients that are just high-risk patients. So you don't have to have a breast cancer diagnosis to come in and get established with a breast specialist. So if you are a high-risk patient, we'll talk to you about getting the additional screening. So in addition to your mammogram, we would do an MRI at the 6 months after your mammogram, and then alternate that with the mammogram and then a yearly MRI. So we will follow you, and you don't have to just feel like you're stranded and you have this high risk and you don't know where to go. So where we have a high risk clinic where we see patients a lot and just counsel them and talk to them about risk reduction strategy. So I think that's important. And then we can talk about all these lifestyle things and what you could do to really reduce your risk if you're a high-risk patient.
So I think a lot of patients are interested in learning about healthier foods and what they can incorporate into their diet. What do you generally advise your patients? You touched upon some things, but are there any other specific things that can help women who are listening to this podcast?
Yeah. So as I said, just keeping a diet of whole foods, avoiding the minimally processed foods. Vitamin D has been shown to maybe decrease the risk of cancer, decrease inflammation. So making sure that your vitamin D levels are adequate, or maybe taking a vitamin D supplement. Some of my patients have been liking the seed cycling. You might have seen it if you look at my social media. I talk about it on there. That has not been scientifically proven by the American Cancer Society. Just a disclaimer. However, we know that seeds do have a lot of health benefits. They have good vitamins like vitamin E, other just good nutrients, selenium, zinc, healthy omega-3s. So what seed cycling is basically during the first 14 days of your cycle, you eat flaxseed and pumpkin seeds, and just like 1 to 2 tablespoons, you can add them onto your yogurt or cottage cheese. And then during the second phase of your cycle, so days 15 through 28, you're doing sesame seeds and sunflower seeds. So sprinkle them on salad, some sunflower seeds, or as I said, into a yogurt. This, as I said, this isn't really backed by any specific studies. I've researched it and I haven't seen anything, but they are healthy for you. And some women say that it makes them feel better by doing this. So that's something that my patients say. But overall, I think just any diet where you're eating whole foods is good.
And I think some of these seeds, especially the flax and the pumpkin, can be balancing for hormones as well. And that may be a reason why women feel better. It's been a great pleasure talking to you today. How can my listeners find you when it comes to where you practice, your social media, and anything else?
Yeah, so I am in Fort Worth, Texas. I am at John Peter Smith Hospital. So I am the medical director of breast surgery for a Acclaim multi-specialty group. So we're a physician group that works at John Peter Smith Hospital. You can find me on social media at Laure Ramsey, MD. I'm also on LinkedIn, Laure Ramsey, MD. And I have a website, laurenramseymd.com, which is just shows everything on there with all the links. Yeah, but it's been really great talking with you as well. It's cool to hear your perspective on everything because, as you said, we have a lot of overlapping patients, but a lot of times we don't get to speak. So it's great.
Right.
To talk to you. Yes.
Often with my breast specialist colleagues, it's when I really need them, as you can imagine. That's when we have that conversation. And then throughout the rest of the year, it's mostly just following along together. But yeah, I couldn't practice and do what I do without you guys.
Yeah, we feel the same. So
thank you so much for being here.
yeah, thank you very much.